Welcome to the AWE segment on FMB needle technique and design. We're featuring the Olympus 22 gauge dual bevel Raptor tip needle. And I'd like to welcome Dr. Tom Savvides, who will be taking us through this journey today, and Dr. Mimi Zhu, who will be also moderating. She's from Kaiser Permanente in Los Angeles, and Dr. Savvides from UC San Diego.
Okay, thanks, Dr. Krinsky. Happy to be here. So right now on the monitor up behind my shoulder, it's the Raptor model tip. You can also see the dimples that help with visualization of this. This is a 22 gauge core needle. We use core needles in order to get larger samples of tissue. We can use these so that you can do fewer passes and you don't necessarily have to do rapid on-site cytology with this. This is commonly used for pancreatic masses, for liver biopsies, and for other things as well, and is becoming somewhat of a standard now that we're using rather than the traditional needles. I'm going to also show you with the needle, if we have it here.
We do.
So you can just flex it here. It's very flexible because of the metal sheath, and this makes it easier to use as well. So I'm just going to go down and put the scope down. Mimi, any other comments you want to add as we're doing this?
No, I mean, I think what's unique about this is the nitinol sheath, as compared to some of the other standardized FMB needles. The fact that it's nitinol makes it much more flexible as opposed to the plastic catheters, which, depending on where you are in the duodenum, for example, it could be a little bit difficult to angulate. Whereas I think you can see how flexible this needle is because of the sheath material that it's using. So I think that's what's quite unique about this particular FNA needle.
Okay, great. And then when we do FNBs, we have a couple of different ways you can do it with the stylet. We'll show you both the slow pull technique, which is using the stylet, as well as you can use a wet technique without a stylet where you pre-flush the needle. So let me go ahead and get the needle right now. And one of the other things which is important is that there's an adjustable sheath on this, and we'll show you a couple things that we just point out with this. We have our sheath, our stylet here. We have the sheath here that's adjustable. And so it's important, that we adjust every sheath because every scope is different. So in this case, it came out at about 3 out of the box. I'm just going to push it in and out. And actually here is at 3, and I can see it pretty well. I'm going to pull it back just a little bit. I'll show you here. Right here is where we're looking at the sheath here, and you can adjust it in or out there. And you can also use the elevator to make sure it's at the right thing. In this case, I'm going to pull it back, and it's going to be about 1.5 is going to be where our sheath is going to be. Okay? And then if it were a real person, we would use Doppler to look and see things to make sure it's okay, but we don't need to do that here. Currently the stylet is back. I usually pull it back a little bit here to sharpen it, so I'm pulling this back to sharpen the needle here. I'm going to drop the safety catch here, and then what we'll do, and I'm going to get this a little bit bigger for us, is you can now see as the needle just pushes up right against the edge of the lesion here. In this case, we're biopsying the liver. We'll do a quick puncture, and you can see the needle's in. You can also see very, very good imaging here of the distal tip of the needle. This is a dimpled needle, so you can see it quite well here. This part's not dimpled. And then what we'll do is we generally will push the stylet in to express out any tissue that may have gone into the needle tip, and then we'll pull it back. And then the slow withdraw method is we slowly come back. I mean, how slow do you slowly draw back?
I usually tell the tech to basically pull back at the same rate that I'm pushing down. So as I'm pushing down, back and forth, and they withdraw. And what you're doing effectively is creating a suction effect within the entire channel.
Correct. So as we suction back, as pull back, it's suctioning, and I'm doing fanning at the same time. There's different techniques to do this, but by fanning through the lesion, I'm getting samples of the entire part of the area that I want to sample, and so we adjust that in different ways. So We're almost done with the pullback. So it's a very slow technique, but by doing this, we're sucking. We now have core within here. And so at this point, we should have our sample. We don't need to do any suction per se. And then we would go and just take this and
Do you
pull
have
it,
any
let her needle.
precise approach to how many times you go to and fro within and fan?
You know, the data is mixed on this. I think, you know, I would, for liver biopsies, for instance, you do 3 actuations, 1, 2, 3. For pancreatic masses, I actually do several times in and out. I like to fan the entire area. I just want to make sure that we get tissue is the main thing.
Right, because there can be areas of necrosis, so you're
There
trying.
could be sampling areas. The more that you sample, the better it is. Another way that we can do this is to, if we have the suction, is using a suction technique, and there's kind of variations on the wet suction technique. But this is where, what I'll do is I'll usually put this on ahead of time. And that what we'll first do is we'll flush, we can flush it to show that we'll flush the needle with saline or water. And we'll just do that here real quick. So just do a quick flush then, man. I'm not inside. Okay, that's good. So now there's water coating the inside. Some people use heparin. This is sometimes used for liver biopsies. We usually just flush it with saline, and there's some data to suggest this may have an increased yield compared to other ways, but different places we use different ways. Then we put our suction on. This is a catheter, and actually that we've now already got a negative suction pulled in here. And we'll do the same thing.
Mimi, do you use a slow pull or do you use wet suction?
I typically use slow pull. I don't typically use suction. I think either there's no great data to say either is superior. I think sometimes I find suction to be a little bit bloodier sometimes, but I know other people have different experiences.
And so that's a good point. So if you use suction and it's bloody, then we'll switch to non-suction. So that's sometimes you'll get more tissue but more blood.
Yeah.
No suction, maybe less tissue, less blood. So it varies. In this case, if you do the suction technique, then you turn on the suction once you're inside the lesion, and then you'll go back and forth and do your actuations. And again, like we said, fanning through the lesion, and that will get you where you need to be. And the other thing which is important is your assistant will often hold this so that you can actually keep in the same plane as the needle. So you can see that there's our plane. And then sometimes after you've done a couple passes, the needle may bend a little bit. That's normal for every needle. Then you just torque it a little bit. But this needle has very good visualization. You can see it's only a 22 gauge needle, but you see it quite well. And then when you're done with what you're aspirating, you just turn this off to suction, because you don't want to have it on, because if you do, when you pull it out, you're going to be sucking out gastric contents and other things. And then we pull it back, we put our safety lock back on, and then we pull it out and then give it to our assistant. And then the other thing that sometimes we talk about is how do you express the tissue out into whatever you're doing. So there's a couple of different ways. How do you do it where you are?
Well, we usually just use the stylet and push the tissue back out with the stylet.
So, and that's
then we flush.
Yep. So the stylet, pushing the stylet out is something that's commonly done. Sometimes we just do straight flushing if we know that we don't need it to be, we're not going to look at it or not do rapid on-site cytology. There's some people suggest that one's better than the other. I'm not sure that it makes huge differences. And then getting back to Dr. Krinsky's question, for pancreatic masses, especially if we need to get enough tissue for molecular analysis, whatnot, we'll do 4 passes is what our oncologists are wanting nowadays. But for other lesions, you probably can get by with 1 or 2 passes. So you need to know at your institution how many passes they want. But it's very good. This seemed to be a very good needle, and I think that it would work well for everything we do on a regular basis.